Good afternoon, everyone. This is Bill Schmidt, President and CEO of the Pulmonary Fibrosis Foundation. I hope you're all doing well during these challenging times. The PFF is forging ahead with our work to serve the pulmonary fibrosis patient and caregiver community as much as possible. So we are pleased to present this webinar today on access to supplemental oxygen advocacy. We know this is a very important issue for our community and a source of great frustration and concern. So addressing this issue is a top priority for the PFF. Before introducing our first speaker, I would like to quickly review some existing PFF resources on this subject. And you should be seeing a slide in front of you now entitled PFF Oxygen Resources. And those resources include an Oxygen Basics booklet, Traveling with Oxygen, Quick Start Guide, and a supplemental oxygen video, which can be accessed through our YouTube channel. We also have answers to frequently asked questions on our website, and we also have an oxygen information line, which is 844-825-5733. Again, 844-825-5733. And in general, you can find a lot of information about oxygen at pulmonaryfibrosis.org/oxygen. I wanted to let everybody know right now that we will be holding questions until the end, until the presentations are done. So right now, it's a real pleasure for me to introduce our first speaker, Gary Ewart. Gary is the Chief of Advocacy and Government Relations at the American Thoracic Society. ATS is the world's leading medical association dedicated to advancing clinical and scientific understanding of pulmonary diseases. And Gary is an important partner of the PFF on this issue as well as others. Gary has over 20 years of experience as a lobbyist in Washington and is really a pleasure to work with and is extremely knowledgeable. Gary is now going to speak really about the public policy history of this issue. So Gary, thank you very much for participating today. We really appreciate it.
Thank you, Bill, for that kind introduction. And as Bill mentioned, I have worked for the ATS in the Washington office for over 20 years, which means I've experienced about 20 years of frustration with Medicare and their policy on oxygen. And I'm going to walk you through that. So a little bit of background. So Congress, CMS, and home oxygen have a long and complicated history. And I won't read the entire slide, but essentially it goes through 1989 to the how Medicare was paying for oxygen as usual and customary and reasonable basis from 89 through a series of legislative actions where they first established a fee schedule for oxygen, then cut it by 30%, then cut it by another 8 to 9%, then allowed it to be put on competitive bidding, and then switched over to the 36-month cap rental. So there's been a long history of CMS and Congress taking action to reduce payments for oxygen. Next slide, please. So what we have here is an interesting situation. And CMS has also done a number of studies on oxygen. So the Department of Health and Human Services Office Inspector General has done several reports on Medicare payment for oxygen, comparing Medicare payment to VA payment, Medicare to VA payment, and studying patient access under competitive bidding. And a long line, again, is that the CMS has long held that Medicare pays too much for oxygen and oxygen services. Next slide, please. And what do we have now? We have a system that pretty much everyone hates. Next slide, please. So what do the prescribers, are they unhappy about? Well, they're unhappy because hospital discharge is complicated by oxygen issues. I know nurses in the discharge unit spend a lot of time trying to get patients who are being discharged from the hospital who need supplemental oxygen lined up with a DME supplier in the right system in a timely manner. I know there's significant challenges in getting patients on liquid oxygen who need the portability and high flow that liquid oxygen offers. For patients who are trying to get portable oxygen systems, that's a nightmare for providers. Competitive bidding providers, prior to the pause in the competitive bidding, were not honoring their contract requirements to provide liquid oxygen. Pediatric oxygen is a significant problem. I know several of the pediatricians I work with who work with patients who have severe lung disease and need supplemental oxygen have problems not just with the oxygen equipment itself, but getting proper mask fit for kids. There's a lack of good education on patients on oxygen systems by DME providers. It used to be that most DME companies would have an army of respiratory therapists to assist with initial setup and handle any questions. Now much of the education conducted by DME providers is done by the delivery man, and not to make fun of the delivery man, but they're not the trained providers and have the expertise that respiratory therapists have. There's complex paperwork involved in ordering and documenting the necessity of liquid oxygen for providers, and patients get locked into one DME provider for several years, which is also a problem for prescribers. Bottom line, prescribers are unhappy with the situation. Next slide, please. So what's the industry unhappy about? Well, the competitive bidding system is not working well in that inexperienced providers are providing lowball estimates. CMS is not transparent in the bid process. The previous linking of DME medical oxygen and sleep equipment had an interesting mix of providers who, to get the sleep contract, had to bid on oxygen even if they didn't want to provide oxygen, or vice versa. If a DME company was a qualified oxygen provider, had to start providing sleep if that may not have been in their line of business. The bid process is way too dependent on price and not aware enough of capacity and experience to provide good oxygen service. And essentially, the lowering of the reimbursement is squeezing out the service component of supplemental oxygen. While Medicare thinks they're paying for commodity good of oxygen, what makes oxygen service works is the service, and that you have good delivery and good maintenance of equipment and staff on hand to answer questions on the use of supplemental oxygen. And the reduced reimbursement is also driving out many quality providers. So the oxygen industry is unhappy about the current system as well. Next slide. I should probably open the microphone here at this point, but it's pretty clear that patients are unhappy about the oxygen situation too. Can't get liquid oxygen, hard to get portable oxygen, travel oxygen costs out of the pocket. And for those with stationary only systems, you're stuck in your home. And now many are required to, instead of accepting delivery at the home, are required to go to their DME providers to pick up oxygen contents. So the system is not serving the needs of patients well either. Next slide. And this isn't just anecdotal information. This is what I'm sharing with you is a graph from a survey that the American Thoracic Society did a couple years ago, asking about 2,000 supplemental oxygen patients their experience with supplemental oxygen. And they could choose several things, but you can show that just this chart shows that there's pretty high unhappiness with the oxygen situation from a patient perspective. Particularly can't get access to specific oxygen systems, but this is just a snapshot that shows there's general unhappiness in the patient population with the oxygen industry. Next slide. What about CMS? What are they unhappy about? Well, that's an interesting question. In our previous conversations, with CMS. I don't want to say they denied there's a problem, but they certainly didn't feel there was a severe problem. And when we spoke with them about the problems from the patient perspective, they shared with us that the Medicare 1-800 number only gets about 3 or fewer oxygen complaints per month. I'll talk a bit more about that in just a moment. CMS is happy with competitive bidding because it is yielding huge budgetary savings, well above what the initial cost projections were. And HHS has done a number of studies, and they seem to feel that there is not a problem with access to any oxygen, including liquid oxygen. And when we talk to them about potential solutions to improve the oxygen market, CMS claims they lack administrative authority to make some of the changes that we are suggesting. Going back to that Medicare 1-800 number, I've called that number a couple times, and it is one of the least user-friendly experiences. And to register a complaint can take about a half hour to go through the phone tree and get to the right person to share the complaint. So to me, there's no surprise that the Medicare 1-800 number is receiving so few complaints, because people don't have that much time to sit on a phone just to complain. Next slide, please. But CMS seems to be awakening to the reality that there's a problem. So this is a fairly wordy slide, but essentially has text from a previous Medicare proposed rule that shows that Medicare is beginning to recognize that there's a problem in the oxygen market. Next slide, please. Again, more text essentially showing that CMS is beginning to recognize that there's a problem that they need to address too. Next slide, please. So what does CMS propose now that they're beginning to recognize that there's a problem in the oxygen market? So they propose adding a portable liquid oxygen equipment class and adding a liquid oxygen high flow contents class, and applying budget neutrality offset to oxygen and oxygen equipment. That last point is essentially a fancy way of saying they are not going to pay any more for oxygen in total, but they will reallocate dollars from away from stationary equipment towards liquid oxygen. Next slide, please. It may be a bit challenging to read, but essentially that slide shows the rates that started in 2018 for liquid oxygen, and it shows essentially Medicare is paying a little more for liquid oxygen in their hopes to alleviate some of the liquid oxygen problems, and they're taking that money from stationary oxygen systems. I think the overall point is, while we appreciate that CMS has taken this step, the amount of monies that they're using are not big enough to really make any changes in the oxygen market. Next slide, please. So what are we doing about it? And when I say we, I do mean the ATS, but I also mean a broader coalition of patient and physician groups who are all concerned about oxygen. So the ATS did the Supplemental Oxygen Survey, and that's been published. That was the slide that I showed you that had the bars showing patient concerns with the oxygen system. That was just one of the many findings of the ATS Supplemental Oxygen Survey. The ATS hosted a supplemental oxygen workshop providing recommendations on both key policy issues and key clinical issues that need to be addressed for improving the provision of supplemental oxygen to respiratory patients. The ATS has partnered with some sister organizations to hold briefings up in Capitol Hill, trying to share with legislators that there is a significant problem in the oxygen market, specifically the liquid oxygen market. We've worked in a coalition with patient and physician organizations to try to get the message out. We've been meeting with congressional staff. We've been meeting with CMS officials, trying to get them to understand both the severity of the oxygen problem and to work with us on some solutions. Next slide, please. So what do we want? And this is an evolving issue. First of all, we want CMS to monitor and publicly report on problems to supplemental oxygen, particularly liquid oxygen. I mentioned that CMS had done some earlier reports where they say that they don't see access to oxygen as a problem. What they were measuring, though, is there a provider in your area who has a signed contract to provide oxygen? They were just measuring whether there was someone who could do it. They weren't measuring whether there was someone who did do it. And I think that was an intentional, they were measuring the wrong thing, and I think they knew it. We're trying to encourage them to measure the right thing to show whether patients are actually getting oxygen, not whether providers are around who could provide oxygen. We also need to get Medicare to recognize that supplemental oxygen is a medical treatment. It's not just a commodity good. This is not like delivering bags of groceries and all you got to do is drop it off and everything's fine. There has to be a recognition and payment for the service component, the RTs that do the initial setup, that handle patients' questions, that do home evaluations to make sure the safety and efficacy of the supplemental oxygen systems. There also is a service component in making sure the correct modality is there. And we think that there should be modality payment specific. So there shouldn't be one price for stationary concentrators and a small bump for liquid oxygen or portable oxygen. Medicare should recognize both the service differential, cost differential, and make a reimbursement differential based on the oxygen system. We also think that flow rates should impact Medicare reimbursement. Now, there already are quality measures or quality standards that DME companies have to meet, but they're sort of administrative standards. They're not actual measures of the level of service they're providing, and we think that CMS should work with the patient and provider community to develop actual measures of the quality of service that are being provided. We think that'll go a long way to improve the service component of supplemental oxygen. And another thing that is somewhat out of the realm of CMS, but is involved, is that because CMS is essentially starving the oxygen market, there's really been no economic incentive to innovate. We're using the same technology for oxygen that we've used for the last 20 years. It would be neat to see people start investing in supplemental oxygen to do longer lasting units, lighter units, better ways of providing this service. Next slide, please. Thank you. So what is our problem? What stands in our way of achieving our goals? Well, one, we're still having a problem with CMS fully recognizing the scope of the problems in the oxygen market, especially the liquid oxygen market. We're having problems with Congress. Congress has so many Medicare problems that they're dealing with, it's hard to get attention specifically to the oxygen market. And also, this is not the most important problem of the durable medical equipment industry. They're fighting other problems with the competitive bidding market. And cost. Medicare spends billions of dollars on oxygen annually. We believe that any real change in the oxygen market is going to require new dollars. And it's hard to get Medicare to focus on spending additional dollars on such an expensive cost. Next slide, please. And I think at this point, next slide, and I think that's the end of my presentation. So just to say the ATS and our sister organizations, including the Pulmonary Fibrosis Foundation, are working hard on this. I wish I had good news to share, but we're doing a good job of defining the problem. We are making progress in getting CMS to recognize the scope of the problem, and we have some concrete solutions that we're sharing with them. Hopefully, Congress will start to focus on this and we can get some resolution in the near future. With that, I'll turn it over to you, Bill.
Great. Thanks so much, Gary. That was a terrific overview. Much appreciated. It's now my pleasure to introduce my colleague, Kate Gates. Kate is Senior Director of Programs at the Pulmonary Fibrosis Foundation. She and I also work together on our government relations and public policy activities. I'm frankly not exactly sure when she sleeps at times, but just a real pleasure to be working with her on these issues. and she's done just an enormous amount of work for the foundation in getting us, up to speed on the access to oxygen issue. Kate is now going to talk about some surveying that we've done of our community regarding access to supplemental oxygen. Kate?
Thanks so much, Bill. And thank you, Gary, for that presentation. That was, it's a extremely complex topic to understand, especially as government things often are, to understand all the regulations and all the things that have happened. And that was a really excellent overview of where we are at. So I appreciate it. I also want to let you know that we've been surveying patients since December of 2018. So around the time that competitive bidding program took its pause, we decided to start surveying patients to see what their experience is with supplemental oxygen. We are concerned that things, instead of getting better, may continue to get worse. So we want to be able to track that over time. So as you can see here, we have surveyed people in December of 2018. Then between May and September of 2019, we did a follow-up survey. And then in December 2019, we did a second follow-up survey. We modeled many of our questions on the ATS survey. That ATS survey is the most comprehensive and best overview of what's happening with people's experience with oxygen right now. So we modeled a lot of our questions after that survey. We had 583 participants in December of 2018, and then 288 of those people followed up in the summer months, and then we had 124 who participated in December of 2019. I also want to make the point that this survey is still on our website. We're still collecting information just so that we can keep an eye on what's happening, see if there are any significant changes. The website that Bill had referenced before, which is pulmonaryfibrosis.org/oxygen. In addition to getting all of the resources there, you can also take this survey if you want to provide your input. If you've already taken that survey, please wait for a follow-up survey. We just have people take that initial survey once, and then we will send follow-up surveys periodically. So what are some of the results that we've seen in our oxygen survey? And this is the way that ours differs probably the most from the ATS survey. The ATS survey had many pulmonary fibrosis patients, but also patients with all sorts of other lung diagnoses, all sorts of other reasons why they needed oxygen. Ours was mainly made up of pulmonary fibrosis patients from our community, so 91% in the first survey, 92%, and then 94% in the second follow-up survey. So this is largely reflecting the experience of the pulmonary fibrosis community. As you know, pulmonary fibrosis patients do need high-flow oxygen in many cases, and they, along with a few other conditions, seem to have a significant number of problems because of the need for access to high-flow oxygen. So again, this is referencing the three different surveys. We have the initial survey in blue, the follow-up survey in green, and the light green, and then the second follow-up survey in a darker green. As you can see, there's a pretty small scale showing here. It's between 48 and 50% of people in all of the surveys said that yes, they did experience some sort of problem with supplemental oxygen, and between 50 and 52% of the respondents to this question had not received a problem with supplemental or experienced a problem with supplemental oxygen. So I believe in the ATS survey, it was just around the same. It was just around 49% or something of people had experienced problems with supplemental oxygen, and we're seeing that really stay consistent, that about half of the people who respond are experiencing some sort of problem with their oxygen. So what kind of oxygen systems are currently used? Stationary concentrators, as you won't be surprised to hear, are the highest. Then portable oxygen concentrators are the next most used modality. Between like 85 and 90% of patients in the survey used the stationary concentrator, and then we had between 60 and 70% using the portable oxygen concentrator. I think what's most interesting are these last two types of modalities of oxygen delivery down here at the end, the stationary and portable liquid. In all of the surveys, between 7 and 8% of people are using stationary and portable liquid. It did not change significantly over the year, at least from the people we were surveying, but it certainly has gone down. We know from other data that the number of liquid users has gone down in the past decade or whatever time frame you want to look at, because of all of the problems that Gary talked about. So this is the percentage of patients reporting any specific oxygen issue that has an impact on their life. Service quality ranged between 26 and 36% in the surveys as being an issue. Not being able to travel, I'm sure that's something that you all are well aware of. If you don't have a portable oxygen concentrator, that's the only type of modality that you can use on an airplane, so that makes it difficult. Also, if you need 4 or 5 or 6 e-tanks in order to be gone for even a few hours, then suddenly traveling is really difficult. And that goes back to the need for innovation. We need better systems for people so that they can travel and get around. Of course, some things like just having the equipment all together is important, but we also need to think about people's quality of lives. We can't expect people to cease all of their activities just because they're using oxygen. Inadequate flow rates, a similar issue, and unreliable equipment, both coming in just averaging around 25% between the 3 different surveys. We only asked this question the first time. In the 2 follow-up surveys, we tried to limit the total number of questions so that people would be able to have the time to actually complete the survey multiple times. And we only had a little over 10% of people saying that they had accessed 1-800 Medicare. So that number that is supposed to be the way that people are reporting problems and getting their problems resolved is not something that's being used. If we see that 50% of people had a problem, but only 10% used the call line, then Medicare definitely isn't hearing about all the problems. I can reiterate what Gary said. I've had to use the call line in a previous position frequently, and it is so unhelpful because of just how hard it is to use. Certainly once you talk to someone, they can be very helpful. I'm not trying to say that the people on the line aren't helpful, but just trying to get to a live person and then trying to make sure that the concerns that you have are being recorded can be very difficult. We had about 25% of people unaware that they could call. We had a portion of people who aren't on Medicare, and then 45% of people who chose not to call. So I want to go ahead and open up the questions that we have right now. The first question is something that Gary sort of addressed, but Gary, I wonder if you could give us a little bit more detail on this. Is anyone doing R&D, so research and development, for lighter weight portable concentrators that provide continuous flow. Despite the fact that there's not a lot of technology innovation happening, I think there might be some. And Gary, I don't know if you have any insights into that.
Can you hear me?
Yes. Mm-hmm.
Yeah.
So short answer is I don't know. That's a question that's best directed to the oxygen industry themselves. I do know I've spoken with executives of the oxygen industry, and while they haven't given a solid answer to that question, they've implied that there's not much financial incentive for them to do that kind of research. So I won't say that there's a flat out no research is going forward, but at least the executives are saying that that's not where they're putting their next dollar as they're making business investments in the oxygen industry.
Kate, this is Bill. I'd just like to add to that. Yeah, I think the incentives are a real problem, but I did want to mention that Three Lakes Foundation, which is based in Chicago, is running a innovation challenge, which unfortunately, because of current circumstances with coronavirus, has had to be delayed. But it's a program to really go out and try to find new innovative solutions in a number of areas relating to pulmonary fibrosis treatment and quality of care. And one of the areas that they're soliciting ideas on is improved technology for delivery of supplemental oxygen. So I just wanted to mention that as something that is going on currently.
Mm-hmm. Great. That's I definitely think there are some individuals who are very interested, people potentially who have even been affected themselves and are looking into this. But it would be great if there were the incentives there to more broadly spur innovation and research and technology. That's a great point. I don't see any other questions at the moment.
Okay.
Let me try and refresh, make sure I haven't missed anything. I've been having a few technology problems here. I apologize. But
while we're waiting for additional questions, this is Gary with the American Thoracic Society. I'll just say that there's a new clinical practice guideline that the ATS is about to publish on the provision of supplemental oxygen, and it will be making some new clinical recommendations, what's considered high flow, what systems are best suited for high flow. I don't think this clinical practice guideline will rock our worlds, but I think it will provide additional evidence to CMS that their current policy does not support expert recommendations on the provision of supplemental oxygen. So I'll share that with the folks on the call, and hopefully that'll be another arrow in our quiver to get CMS to start updating some of their oxygen policies.
Gary, this is Bill. That's really great news. I think that really will be helpful. So congrats and thank you to you guys for doing that.
Our pleasure.
Definitely. The next question is, will this presentation be available afterwards? Yes, we make all of our presentations available both on our website and also on our YouTube page. If you go to the Pulmonary Fibrosis Foundation YouTube channel, there are already a lot of webinars there. There are other shorter videos, including one on oxygen, the one on oxygen that Bill referenced, and this one will also be available there. That one. So there's, let me see, I'm sorry, I'm trying to look at the questions. Yeah, so there's someone who's made a comment that liquid oxygen only. There's one DME contractor in the area that will not provide all new customers with liquids. So it sounds like there's a person who's experiencing that they have, they're in an area where there's limited supply of liquid oxygen. Maybe people who have had it before are still receiving it, but new patients aren't receiving it.
Yeah, thank you for that comment. As I'm sure many of the people on the line know, it's not just rural underserved areas that are having problems with this. I've spoken with discharge nurses at Palo Alto, at Stanford, and discharge nurses at University of Pittsburgh, and they can't get liquid oxygen for their patients. And those are some fairly urban, affluent areas where you would think there wouldn't be access problems. So the access problem is not just limited to remote areas. It's an economic system-wide problem.
Mm-hmm.
Yeah.
It's an important point. I know, for example, like the Denver area specifically has a lot of problems accessing oxygen, and obviously at altitude their patients are in even greater need of high flow. So there are many places around the country that are experiencing this. Okay. So there are a couple of questions that we will follow up with you afterwards about the question. I'm going to need to talk with our chief medical officer about a couple of these questions, but do know that if you asked a question, we will follow up with you afterwards. Gary or Bill, do you have any other comments?
Just I appreciate the opportunity to be part of this webinar, and look forward to the continuing partnership between the American Thoracic Society and the Pulmonary Fibrosis Foundation. We got a lot of work to do, but it's good to have good partners to do the work with.
And this is Bill. Well, thank you, Gary. Can't thank you enough for taking the time and providing this information. And Kate, thank you for your presentation as well on all the work you've done on surveying the PFF community on this important issue. And I want to thank everybody for participating in this webinar today. And feel free, as Kate said, to submit any additional questions if you happen to think of them later. And just know that the PFF is going to continue to work hard with ATS and others to try to find solutions to this very, very frustrating problem. Thank you.